Myself Dr. Gunjan, and as you can see, today again we'll continue with the menstrual cycle series, and in this we'll revise all the important points that we have studied till now. And all these points are very important. You have got questions from each of these lines. Now, the ovarian cycle, it is initiated by, and the answer is FSH, the follicle stimulating hormone. The second question, the size of the follicle just before ovulation, and it is 18 to 20 millimeter. Then for LH surge to occur, the estrogen, it has to remain at peak levels for 48 hours. And what is this peak level? It is 200 picogram. So the estrogen, it should be remaining at 200 picogram levels for 48 hours for the LH surge to occur. Now another important question. This LH surge, it occurs 32 to 36 hours before ovulation. Sometimes you get in the option 24 to 36 hours, and even this is fine. So the LH surge, it starts occurring 32 to 36 hours before ovulation. Or in other words, you can say that ovulation occurs 32 to 36 hours after LH surge. Then if you are asked about LH peak, then this ovulation occurs 10 to 12 hours after the LH peak. Then another question, the time interval between the estrogen peak to the LH peak, and it is 14 to 24 hours. And to answer all these questions, just remember this graph I had told you. The estrogen level, it has to peak for 48 hours for the LH surge to occur. Then 36 hours after this LH surge, the ovulation occurs. The next question, the ovulation occurs 10 to 12 hours after the LH peak, and the time interval between the estrogen peak and the LH peak, it is 24 hours. Then this LH surge, it is initiated by estrogen and it is maintained by both estrogen and progesterone. So always look for your question. If you are asked the LH surge is initiated by, then your answer will be estrogen. But if you are asked it is maintained by, then your best answer will be estrogen and progesterone. Why progesterone also? Because I told you that at low concentration, this progesterone has a positive feedback effect on LH and FSH, and thereby progesterone also contributes to the maintenance of the LH surge. So before ovulation, there is both LH and the FSH surge, and even the estradiol surge. So all these three hormones, they rise in the mid-cycle before ovulation. So the main hormone in the first half of the cycle, it is estrogen, and in the second half of the cycle, that is the secretory phase of the menstrual cycle, it is the progesterone. Then another very important fact that you need to remember is that the luteal phase, it's always fixed for all the menstrual cycles, whether it be of 20 days or 28 days or 45 days, the luteal phase is fixed and it remains of 14 to 15 days. And it is because of the prolongation of this follicular phase that the cycle length varies. So if a cycle is of 28 days, the ovulation will occur on day 14. But if suppose the cycle length is of 35 days, then the ovulation will occur 14 days prior to this, and this will be around day 21 or day 22. So the luteal phase, it remains fixed. It is the follicular phase which changes. So to count for the day of ovulation, you should count 14 days backwards from the menstruation date. And what do I mean when I say this? For any female, if you have to calculate that when the ovulation has to occur, then you first have to calculate that when is the expected date of the next menses according to the length of the cycle. And from that expected date of menses, you have to calculate backwards 14 days, and that gives you the date of ovulation. Then the next important point, that the HCG maintains the corpus luteum in pregnant females and LH maintains in non-pregnant females. Then you are asked the lifespan of the corpus luteum, and in non-pregnant females it is 10 to 12 days, whereas in pregnant females it is 10 to 12 weeks. And it is at this 10 to 12 weeks that luteoplacental shift occurs. And what do I mean by this? The function of the corpus luteum, that is to secrete progesterone, it now shifts from the corpus luteum to the placenta, because at 10 to 12 weeks the corpus luteum degenerates even in pregnant female. Then you get a question that in pregnancy, what prevents the corpus luteum from undergoing luteolysis? And your answer is HCG. So these are all direct questions. Now coming to important points about the level of hormones, and all the hormones peak at the time of ovulation. The estrogen, the LH and the FSH, they all peak at the time of ovulation. The estrogen peaks just before the ovulation, that is around 24 to 36 hours before ovulation. The LH peaks 10 to 12 hours before ovulation, and the progesterone, it peaks at day 22 of the cycle, that is 8 days after ovulation. We told that the maximum activity of the corpus luteum, it occurs on day 22 of the cycle or day 8 after ovulation. So this corpus luteum secretes progesterone. Therefore, if you are asked that the progesterone level peaks at what day, then it is day 22 of the cycle or day 8 after ovulation. So what are the important things happening around day 22? The progesterone peaks over here, the size of the corpus luteum is maximum, and all the ovulation tests, they are done at day 22, because we expect that by this time the ovulation will have occurred. So whether you are asked when does the progesterone peak, or when is the size of corpus luteum maximum, or when you do the ovulation test, the answer for all of them is day 22 of the menstrual cycle. Then at high concentration of progesterone, I told you that this progesterone, it causes a negative feedback action on LH and FSH. So if you look at the graph for this hormonal levels, you can see here that this FSH, the estrogen and the LH, they all peak just before ovulation, and after ovulation it is the progesterone which peaks, and this progesterone peak roughly corresponds to day 22 of the menstrual cycle. Now if you try to correlate all the three things, the follicular growth, the hormonal levels and the endometrial cycle, then you can see here that the follicles grows in size. Along with this, the hormonal levels, they keep on increasing, and the endometrial proliferation keeps on occurring. Then when the follicles, they become maximum size, that is 18 to 20 millimeter, ovulation occurs, and just before the ovulation, the estrogen, the FSH and the LH, they all peak, and subsequent to this, ovulation occurs. Now after ovulation, the follicle gets converted into corpus luteum, they start secreting progesterone. So the progesterone level peaks, and the level of all the three other hormones, the FSH, the estrogen and the LH, they fall. And during this time, the endometrium becomes secretory. Under the effect of progesterone, the endometrium becomes secretory, and subsequently when the progesterone level will fall, there will be shedding of the endometrium leading to menstruation. So this was all about the menstrual cycle, and you get many questions from this cycle, that on day 8 what happens, on day 12 what happens, or they last day 22 what happens. So you should remember this entire interaction of the hormones. In the follicular phase, the estrogen is the major hormone, so whatever happening is here is under the effect of estrogen, and in the luteal phase the major hormone is progesterone. So whatever is happening, it is under the effect of progesterone. Now here one hormone that we did not talk about, and that is the AMH, anti-Mullerian hormone. So few words about this AMH. And this anti-Mullerian hormone, this is the one which promotes monofollicular growth. We know that in human beings, in every cycle, one follicle becomes dominant, it grows and ovulates. And this AMH plays a very important role in this. This AMH, it inhibits the initial recruitment of the primordial follicles. The initial stage, the first stage, recruitment of the group of follicles, this is inhibited by the AMH. Secondly, it decreases the responsiveness of the follicles to FSH, and thereby inhibits the further growth of the follicles. And subsequent to all this, it helps in monofollicular growth. And this AMH, it is produced by the granulosa cells of the ovary. Again, one important question. So the follicles with maximum number of FSH receptors, they produce less amount of AMH, and thereby they keep on growing and become the dominant follicle. Now this was the menstrual cycle. Now coming to an important term here, that is Mittelschmerz Syndrome, and let us see what it is. This is basically the mid-cycle pain in abdomen at the time of ovulation, so also called ovular pain. It typically occurs in the mid-cycle and usually situated in the hypogastrium or one of the iliac fossa. And usually it remains in the same side. It does not change from side to side according to the ovulation. I told you that this is the pain at the time of ovulation, but this does not mean that it will change its side. it remains on the same side. And typically it is not associated with nausea and vomiting. This lasts for less than 12 hours and may be associated with light vaginal bleeding or excessive mucoid vaginal discharge. So many times you get a question and they will give you all these features, that pain situated in the hypogastrium, not associated with nausea, vomiting, associated with light vaginal bleeding, and it's always the Mittelschmerz Syndrome or the ovular pain. And what is the cause of this Mittelschmerz Syndrome? It is basically because of the increased tension in the Graafian follicle, and subsequent to ovulation, the follicular fluid which is released, that causes peritoneal irritation, also contributing to the pain. And usually the treatment for this is reassurance. You just have to reassure the patient that this is a normal thing. But if it is very disturbing, then in these cases you might have to give oral contraceptive pills to make the cycle anovular. And if ovulation will not occur, then again this pain will not occur.